If I'm in the way, shout at me to get out of the way, or I'll sit down or something, or squat, so you can sort of see the pictures. It becomes more interesting later on because I've got some film by kind courtesy of the company, pictures and film of people. All of the film, actually, I think all of it is MS, isn't it? That we've got on there, so you can have a look at how it's affected some people, and you can see what we've done to try and manage it. But as Richard said, my background is, I am a physio by trade and have taken early retirement from the health service to work for this company. But my background is that I worked in adult neurology, not that far away from here actually. I was in Newmarket for 16 years and worked in Bury St Edmunds and Haverhill and around the area. Then I moved up north and I now live near Manchester, but worked on the MS team in the Walton Centre, which is the regional neurology and neurosurgery unit for the Northwest. So I can ball for England on MS if you really want me to. I won't, but I could. But then, and I have used Lycra in clinical practice since 1998, and I'll tell you about that as we go along. And so I can give you some idea of how it may be able to help some of your symptoms. But some of you will sit there and think, well, actually, that's not going to help me very much, and it might not. But anyway, I don't need to tell you this. MS is a very complex and multifaceted condition, and it's quite difficult to treat some of the symptoms. But we're going to actually look at some of the techniques that you can use to help with one at the front, if you like. So that you can, what we can do to try and manage both tremor and spasticity. If you can't hear me, if I say something that's absolutely ridiculous, if you want to ask a question, please interrupt me as we go on. This isn't supposed to be me standing up and spouting, because you probably get sick of the sound of my voice. I do, so I don't see why you shouldn't. But anyway, so we're looking at tremor first, and there's been some studies done that actually about a third of people with MS actually get some sort of symptoms of ataxia and tremor, and that's been shown in a couple of studies. So that's quite a high proportion, really. But then there was another study done of 100 people with MS, and you can see that more than a third of people actually had some sort of symptoms of tremor. How many in the room have got some sort of symptom of tremor? Well, that's at least a third, I would say. Just going very scientifically and very random. But those of you who've got tremor will probably be very well aware of the sort of things that you tend to do to try and control it. If it's your arms, you might use both hands to reach for something, or you might sort of hold on to one hand doing something, or if you haven't got those symptoms, you might have noticed it in other people. And people change their posture, and how many people actually sit on their hands because they're worried about them, from shaking too much. It's actually quite nice if I keep coming here because I get a quick drive up my back. You'll notice I'm a very serious person. So in terms of tremor, there's different strategies, none of which is absolutely wonderful. There's medication, there's surgery in a small number of cases, there's Lycra, which we'll talk about, and there's also exercise. And of course, Neil and I are physios, so we're all into exercise and making people move around. The medication has variable results with people. The most common two are isoniazid and propranolol. There are others. Some people have very good results, other people don't, but then we're all individuals, which is a kind of nice thing to be. The surgery, you may have heard talk about stereotactic lesional surgery or deep brain stimulation. This is only appropriate for a very small number of people, and it does carry risks to it, more than Lycra. If you can't cope with Lycra, you just take it off. You can't reverse brain surgery, really. So it's there, and it can be really helpful for some people, but it is small numbers, and I think that's important to say. Exercise. Now we bang on about exercise. The epitome of. I don't know what you're laughing for. I should make Neil stand up really, because Neil is the epitome of exercise and fitness. I'm short and fat, but I'm reasonably fit for somebody of my age, which is not bad. But exercise is important, and there's lots of studies out now that show the efficacy of exercise for MS. I think when I first dealt with MS, years ago, the theory was that you don't exercise because you might make it worse. and that's how it was for a long time. But that's been proven to be absolutely load of rubbish, and exercise does actually help a lot. Now, I don't know about your experience, but in my experience of dealing with people with MS, quite often you get given that diagnosis, which is that label, and then you kind of think, I don't think I should be doing that, because actually if I do that, then I'm going to get too tired, and if I get too tired, then that could make it worse. And that's not actually true. There was an interesting study done, and I need to look it up. I'll get Neil to look it up. There was a study done on fatigue in MS, and everybody talks about MS fatigue, and there is MS fatigue, absolutely. You know, I'm not disputing that. But a high proportion of the people in the study did an exercise program, and it wasn't their MS fatigue that was the problem, it's they were out of condition, and their fatigue got better when they went on an exercise program. So it's kind of it's an interesting thing, and one of the things I have done in my past is I did do an exercise book for people with MS. That came out in 2004. I then went on to make an exercise DVD with Mr. Motivator. He has kissed his face, what can I say? But there we are. But we did that because we know that exercise is really, really important, and you can't always do. I mean, you know, look at Neil. Picture of fitness, health. I mean, I'm sure, do you run? I don't know what he does to keep fit. So he runs, but how many of you would feel comfortable in going out running? Well done, that man at the back. But, you know, you wouldn't necessarily feel comfortable about running, but so then you think, how do I get out of breath? It's really quite difficult, isn't it? You think, what do I do to get out of breath? My favourite activity for getting out of breath, when you can't run, sit in a chair, arm jog. I'm not going to make you do it now. If it had been a cold day, I might have done. But if you sit an arm jog and you give it a real bit of way, after 1 minute, I can guarantee you're breathing deeper and your heart rate's gone up, which will have an effect on your fitness. Yeah? So, and my personal favourite is actually punching the air, especially if I'm watching the adverts on the television. See, I've actually trialled all this for people, because obviously if I'm not willing to do it, then why should I tell you to do it? If you punch the air when you're watching the adverts, especially one that really irritates you, top of the list? The Go Compare Man. Well done. It is, it's still top of the list. So every time the Go Compare Man comes on the telly, if you do that, no, don't punch the telly because that's a bit expensive, but again, you're going to get your circulation moving, you're actually going to breathe deeper, it's going to have an impact on getting you fit. They're thinking, oh, bother with the exercise. Actually, you can. Everybody can exercise. And if you've got problems with your arms and your arms are a bit weak, sit at a table, get a duster and polish the table with gusto, because then you've got the support of the table to hold your arms up. So there's a way of doing it. So you can tell I'm a physio, I find a way around everything. When we're talking about tremor, though, in particular, lots of the exercises that you may have been given by therapists up until now, really, are ones that will correct your posture, and that's very important. We do need to correct our posture. The other is a thing called stabilisation exercises, which is a way of adding a resistance and making you keep your balance. Anybody done those? Had the physio trying to knock you over? They're always satisfying for physios. And the other one, of course, is using weights, because weights tend to dampen down tremor. If you add a weight to a wrist that's doing this, it'll dampen down the tremor. The problem with weights is they can be very tiring, and when you take them off, it can make your tremor a bit worse. But that's, you know. So, but you can do, you know, there's a lot of resistance needed when you're actually using weights, and you can add weights to garments, you can have weighted cutlery, you can have all sorts of weighted bits of equipment. But as I said, it can actually, you know, it can dampen down the tremor, but what it can do is make you more wobbly when you come out of it.
You haven't mentioned it in legs, because I get it in legs, not arms.
I wasn't specifying whichever bit.
Yeah, but
tremor happens
those exercises.
But that's because they can't see my legs as well. We'll talk about, we'll look at, and I'll talk about, because when I come on to Lycra, I'll talk about not just arms, but what you can do in terms of legs. But they will use weights on legs as well. You can put, you know, the weights you can buy from Argos or any sports shop, you can wrap around your wrist, you can wrap around your ankles as well, and add a resistance.
Do that high.
Yeah. Yeah, and of course in hydrotherapy you're using water as a resistance as well. So, you know, so those things are good. Okay, so that's a very brief overview of tremor, but when we look at spasticity, and some people have mixtures, they do have spasticity as well as having tremor, because MS is one of those wonderful conditions that gives you mixed symptoms. And I've just put a sort of a very general list of some of the symptoms that you may have if you have spasticity. It's not an exhaustive list, and some of you may have other symptoms that I haven't heightened there, but a lot of it is about resistance to movement, particularly to passive movement. If somebody tries to move your arm, or you try and move your arm or your leg or wherever, and it feels stiffer, there's a resistance, you can't actually move it as smoothly. And even when you try to move it, you can't move it as fast because there's a resistance there. Yes? Some of you nodding? Yes? Recognising that? Other people have spasms and they take on a different format. They can either be that your leg suddenly shoots out and it's really difficult, or your whole body goes, or your arm comes up, or you can actually have flexor spasm, you can have extensor spasm, you have all those sorts of things as well, and they can be quite difficult to deal with. How many of you know what clonus is? Yeah? Anybody else? You know when somebody puts their foot down and their knee jumps up and down, and you probably can't see me doing that very easily, and the knee goes jumping, that's clonus. It's just a posh name for what that is. Yeah? So if you've got your foot like that and it's doing that, that's clonus. Yeah? That's what that is. Okay? So clonus is a form of spasticity. And what it basically is that your calf muscle is trying to push your toes into a pointed position, and it can't do it because you've got some weight on it, and so it's actually vibrating and bouncing your leg up and down. So that's called clonus, which is different from tremor. It's not the same thing. Okay. When you've had your reflexes done, usually at the doctor's or at the hospital or wherever, the reflexes that the doctors find, or the nurses or the therapists, whoever's taking your reflexes, will find they're much faster than in the average. So, you know, we all as kids, you always do your knee, don't you, when you kick. But in MS, you quite often find it's a much faster reflex than it would be in, and I hate, with a passion though I hate the word normal, but people without MS, you'll find it that it's a faster reflex than somebody like myself or somebody like Neil, and there's that. The other thing is associated reactions. What we mean by that is, if when you walk, and you've got a bit of a tight arm, when you walk, if your arm kind of pulls up with the effort of walking, that's an associated reaction, something that happens alongside you trying to do another task. Yeah? And so that can be a form of spasticity. And also you change the pattern of movement. And unfortunately in MS, what you do find is it tends to be quite mixed. You know, if somebody's had a stroke, it's a bit easier because what tends to happen is the arm will do that. In MS, it will often do that, but I have seen people where their arms go on kind of straight and it can sort of change position. But it's where you have these altered postures. And also when you stand and you move around, you actually change the way in which you actually walk. And you can be kind of like this, you can do all sorts of things. So it's altered patterns of movement. And I could go on, there's lots of other things as well that happen with spasticity. And you, of course, because of all those things, you compensate as you do with the tremor. And it can be you change your movement to cope with it. And it's that sort of resistance, and you might sort of change the position of your arm to stop it going into pattern. You get that jerkiness, that jumping. Some people get pain with spasticity. Anybody here get pain? Yeah, quite a few. It's interesting because that was another thing that's changed over the years. That when I first learned about MS, so nobody with MS ever gets any pain.
Yeah.
What a load of twat. Yes. You know, your mobility changes, you compensate for how you move and how you walk, and I've already shown you that. Lots of different ways in which you can manage spasticity, and often it's a bit of several. You may do all of these, you may do some of these, you may do one of them. Again, there's medication. Most of you have probably been taught how to stretch your muscles. Standing is the most fantastic exercise, particularly for legs, And you've got a lovely standing frame over there. So, you know, standing probably really good. Positioning when spasm gets very bad, sometimes your positioning at night time needs to be slightly different so that it can help cope with that. Splinting, and we're talking splints other than lycra splints, and functional electrical stimulation. Anybody use that here? Yeah? So do you all know what it is? No? It's where you have electrical stimulation to muscles that don't work so well. Usually it's used on the lower leg to help pull the foot up so that when you walk you can clear the floor with your foot. And it can be incredibly effective, but it can be a bit tiresome to put it on because you have to have a little electrical box and you've got leads and you've got to stick it on the right place on the muscle. You've got to have another lead that goes under the insole of your shoe that acts as a switch so that as you hit the floor it switches on so that when you then pull your foot up it works. But some people don't like it because the electrical stimulation can actually be quite uncomfortable. Most people do get used to it, would you say? Yeah, those of you that use it? But not everybody does. Not everybody likes the feeling of FES, but when it works it can be fantastic. And then lycra, but we're going to go on to lycra in the end. The medication, I mean, I could go on forever. I'm not a nurse or a doctor, so I'm not an expert in medication. But the common ones are baclofen, a gabapentin, a tizanidine, dantrolene. I mean, there's loads of them. And oral meds just means tablets or liquid. Some people have them in liquid form. Recognise the names, most of you, I would imagine? Yes. Baclofen is the most common. It's actually a really old drug, but it's actually one of those that's really quite safe for people to take. So it's still one that they actually use quite a lot, but then there's the others. And then for more severe problems, they now use what's called intrathecal medication, which is that they introduce a small tube catheter into the space in the back. And then with a baclofen, they do it by a pump. So you have a little reservoir that sits underneath the skin, and then you've got this tube that goes round into the gap in the spine, and it delivers the medication directly into the spine. So it means you can have much lower doses. But of course, that's for people with very severe symptoms, and it's very expensive. But I'll tell you a story about somebody who I thought ought to have had that, and what we did with her in the end. And then there's another drug called phenol, but phenol can be a little bit destructive, so but that it is another one that is used. So stretches. Now usually it's us physios, us physio-terrorists, that actually teach people how to do stretches. It's either teaching you yourselves or it's teaching your partners, your friends, your carers to actually do some stretches, because if your arm is tight, and I'm just using the arm because you can see it, but if the arm is tightening up, then you need somebody else to be able to pull it out against that patterning. Because spasticity happens in patterns, and you need to break the pattern to actually stretch the muscle out. But a lot of people do stretches, but even all the athletes that are going to do the Olympics, they do stretches on their muscles as well, because obviously you don't want everything tightening up and shortening. So there's that. In terms of standing, that's one way of stretching too. So if you're standing in a standing frame, you're getting a lovely stretch on your calf muscle. You're not allowing your toes to go pointed, it's bringing you up at a right angle. But you can use a standing frame, but people use furniture. We all use furniture, don't we? And if you're doing stretches, a lot of people will stand in the kitchen and hold on to the kitchen sink, or they'll have a bar somewhere that they hang on to, or they'll lean on a top somewhere, or a bookcase, or whatever. But there's lots of places around the house where you could actually stand and use furniture. And then I mentioned positioning earlier on, and sometimes you need specific positions, especially for sort of sleeping arrangements. But you can, if you have problems, if any of you who are using wheelchairs quite a lot, if you have problems, for example, with your legs clamping together, especially if you're being wheeled or you're pushing yourself over bumpy roads, and your legs suddenly go into a spasm, sometimes it can be helpful to have some sort of roll in between your thighs to actually pull the hips out a little bit, and it just minimises the clamping together of the thighs. Hospital towels are about the right size for doing a roll there. Okay, Splints, now there's a whole variety of splints out there. There are some that are made to measure, and some people, you know, you'll get therapists, physios and OTs will make a splint to actually sort of, sometimes you have a night resting splint for arms and for legs, and the therapist will make those for you. Sometimes you get them off the shelf. How many of you have got one of the plastic things that goes into your shoe? The sort of right angle thing, yeah, a few of you. And there's a variety of those. There's the one that just goes straight down in a right angle, and then there's others that sort of come down and, you know, made up of carbon fibre and things. So they're all static splints that kind of hold the body in a position, or the body part into a position to try and keep your muscles stretched. So that's what I mean by splinting. And there's a variety of them out there. Okay, and I've already mentioned this actually, but the functional electrical stimulation, basically what you're doing is you're activating the weaker muscle group, so you're counteracting where the spasticity is happening in the bigger group. So in the lower leg, for example, it's your big calf muscles. I mean, you know, in me they're very big, I have to say. If you know, they're a big muscle group, and in certain people they're enormous muscle groups, particularly myself. But that means that they're big muscles working against the relatively small muscle that pulls your foot up to clear the floor. So what FES can do is counteract that. And some people use it as an exercise thing rather than just when they're walking as well. But it can actually, what I find fascinating about FES is that even when you're just stimulating one muscle group, it can make the whole leg appear more stable. And I don't quite know how that works, but it does. So it's really quite nice to see. So, would that be your experience of dealing with those sort of symptoms generally? Have I covered the sort of things, the management strategies that you have come across in the past? Yeah? Okay. So now what we're going to do is we're going to look at what you can see up there is written dynamic movement fabric orthoses. Now what they are is what you might know as lycra garments. Had anybody come across lycra garments before you knew I was coming to talk to you today? You have, yeah. They've been used historically in cerebral palsy children for many years, and so it's quite normal practice for them to happen in paediatrics. It's now sort of expanding into the adult world. Well, I think I'm going to say exploding, because we've just taken on 3 new members of staff in one go, and we're a small company. Because we're getting so many more referrals, both in paediatrics and in adults. My role is to try and spread the word amongst the adult therapists and people who may benefit from the use of lycra. And I have to say, I'm doing stupid amounts of mileage at the moment, so I'm really pleased to have people like Neil on board, because actually, you know, we're going to be able to cope a bit better, and I might be able to relax a little bit more. I doubt it, but anyway. So, they're actually quite flexible. This is not one that will fit me, but you can see they're very flexible, so it's just like wearing clothes in a way, but they're specialised clothes. And they're all made to measure, which means that they will fit you more comfortably than maybe a standard splint might have done in the past. But it also means that what we can do is tailor-make it to the individual needs. Now, if you look at for those of you who can see it, the blue suit on the far end there, that's a standard bodysuit. Now, dealing with adults, I don't deal with many bodysuits, to be fair, although I have got a few. I tend to use gloves and socks and shorts and stuff. But that's a standard bodysuit. This one isn't a standard bodysuit, so I want you to, can you spot the difference? Apart from the size. It doesn't quite fit me, this one. So what's the difference between this one and the blue one on the screen? It's got a hole in the bottom. Yeah, that one hasn't actually, has it? Yeah. What else? The zip's in a different place. So that zip goes straight down the middle. Yeah. This zip goes offset. Now this is for a child that would, you know, some people are fed by tube, so they might have a peg feed. So what they'll do is they'll send this back to the factory and create a hole where the peg feed needs to go. So that's one way in which we tailor-make them, so that you can do that sort of thing, particularly in children with cerebral palsy. But in adults, sometimes adults don't necessarily want to wear a bodysuit unless it's going to make a big difference to them. So sometimes I'll adapt a pair of shorts and make them a long pair of shorts instead of a whole bodysuit, because especially when the weather's like this, you might want to have a bit more of an open top, as it were. Yeah? So, we have got quite a few samples of lycra here, so if anybody wants to try at least a glove on while we're here, please feel free, and we'll throw some out in a minute and get a couple of people to put them on, so you can actually feel what they're like and what they actually do. It doesn't have to be on a part of your body that's got a problem, but just, you know, if your arms are okay, you can still put it on and you can still feel what it actually does for you. So we'll do that in a minute for anybody that wants to. So it is flexible, you've just seen that, it conforms well. It is less invasive than some of the conventional orthoses, that's splints, because the rigid splints sometimes can be quite uncomfortable if they're not made to measure for you, and also they're very rigid. It's a breathable material, it's an open weave material, which means it's also washable, and these garments are washable now because washing machines go down to 30 degrees. You can wash them in the washing machine on the 30-degree cycle. And all these, when I go home tonight, well, I might not do them tonight, I might do them tomorrow, they'll all be washed at 30 degrees in my washing machine. I won't do them by hand.
So what are they supposed to do?
Do you want to try one on? Or do you want me to put Neil in one?
No, you can try one, but the thing is, it's this leg.
Well, let's not worry about your leg. Try one on one of your arms so you can feel what it does in your arms. Do you want to put that on, Neil, while we're... That's one sponsored by Asda. And what they actually do... You might want to slip your watch off. What they actually do is they put compression on the arm, and I think that's the one that fits me, which is a shame, because never mind, I'll change in a minute. So what they actually do, this is a slide that one of my colleagues put together, they have twofold effect, what we call a neurophysiological effect, which actually has an effect on muscle tone. So where the tone of your muscles might be quite tight, it can help to relax that tone and sort of make it feel softer. It also will tell your body where you are in space. Now, if you've got a body that shakes a bit or is a bit like that, it can actually improve your posture and actually make you a bit more aware of where you are in space. And it also has an effect on what we call the sensorimotor feedback feed-forward, which sounds dead posh, but it isn't really. The sensory input is what you feel. And when any of you that have had therapy will know that the physios and the OTs put their hands on you, and if they're trying to help you walk, it's nearly always round here, and you see physios the world over doing this as they're walking people. And it's so that it gets you to feel how you should walk and where you are in space, and tries to even you up if you walk slightly lopsided or whatever. And so that's what the sensory motor feedback feed-forward. You might need to twist it round before you do that one up. But it also can change it biomechanically. It will have an effect in that it will change the symmetry of your posture. Oh, you want to try doing it on hairy men? It's great. But you can actually maintain and improve muscle length because of the way it holds your position. It actually sort of stops your muscles from tightening up and getting too short. And when we start looking at things like shorts and the shoulder, it can actually improve your stability around what we call the core. So it's actually sort of keeping you more stable. How are you doing there? Is it a bit slow? Ah, that explains a lot. There you go, that's not a bad fit. What's your name? Anne. So Anne's got a nice long glove on here. Okay. Apart from feeling quite tight, Anne, what does it feel like? Let your arms hang down by your sides. That's difficult because you're sat in a chair, but let them relax. From here, it's very subtle. I'll put it on me in a minute because I know that one fits me and I know the effect it has on me. But what it does for a lot of people is we'll pull the arm outwards and change position. a little bit. Now, if you do that on both arms, what's that doing? Is it harder work pulling it inwards? Is it harder work doing that? Not particularly, she's too tough, you see.
I've got very strong arms.
And when your arms are not affected, it's going to be a more subtle position.
Yeah.
Now, what is quite interesting, now she's rested her hands up, is that the left hand is on her scooter that way, and the right hand is now up that way, because it doesn't want to sit down there, so it's actually pulling her up. So that's the biomechanical effect of changing the posture. Even if she's not particularly aware of it, it's actually making her do that, rather than sitting with both hands on the top of the scooter.
Well, it is actually.
Yeah, it's now pulling you out a bit more. The longer you have it on, the more effect it actually has. Okay. No, because, I mean, these are all samples, so they're not going to be made to measure for you, so they might be a little bit too tight, and I think that one is a smidge too tight for Anne. But when you normally do them, they're made to measure for each individual client, so therefore they should fit you perfectly, so no, they shouldn't cut off the shirt circulation. There's something wrong with the measures if it's too tight. I mean, it should not be too tight. It should just be like wearing something snug. How many of the ladies in here have worn magic knickers? Yeah? Now, they feel quite tight, don't they? But they don't cut off your circulation. But you're quite aware of them, aren't you? But you're quite aware. And how many of the men have worn sports compression shorts? Yeah? So when you wear those, they're quite tight, but they don't affect your circulation. Yeah? Now, if you think Lycra might help you, you could do no worse than either using a pair of magic knickers or a pair of sports compression shorts to see whether it gives you a bit more core stability, or even a wetsuit, same sort of thing. If you get that compression, then it can actually help your stability at your core. Okay? How's that feeling now? See, it's definitely pulling your arm out because you can't rest it down, can you? No. Yeah.
No, it's making it go like that.
Yeah. And do you feel that you're more aware of that arm than you are of the left one at the moment?
Yeah.
Yes. So that's the awareness of the position of the body in space. So, you know, that's actually what it will actually do for you, is we'll change that. Now, with somebody with tremor, do you want to take that off now?
Yeah.
Do it tight, and I'll let Neil do that for you. When you've got tremor, the other thing that it will do is it can dampen down the tremor. And I sound as if I'm sort of going to give you a confession, a bit like somebody going to Alcoholics Anonymous, but I'm now going to tell you what got me into Lycra. When I was working in Newmarket, not that far from here, I had a young lady who'd been diagnosed with MS as a teenager, and she had an arm that was doing this, which was somewhat inconvenient for her. But because she was being treated by the paediatric physios at the time, they put her in some Lycra by a different company to ours. But it kept her arm still, which was really important, because obviously if you've got an arm that's shaking all the time, that's really quite hard work. Now, unfortunately, the other company is quite a lot more expensive than we are. So when she came into adult service at the age of 18, I didn't know anything about Lycra at that point. This is 1998. Didn't know anything about Lycra. Never come across it, you know. So, but the health authority is saying, you know, that at the time the Lycra that she was in was costing over £1,000 a year. So the health authority kind of went, oh my goodness, we can't afford that. Let's find something cheaper. So I then, I won't tell you the whole story, but I then met Martin, who is now our boss, who's actually an orthotist, a splint man, and he had been working on designing the Lycra garments for another company at the time, but he then bought them out and we became Deal Orthotics. But he came and looked at this girl and put her in a long sleeve glove, not unlike the one that Anne had on, so it was right up to here. And we sent her away and we said, well, go away, try it, see how it feels for about 3 weeks or so, come back and then tell us what it's like. If it's not as good, then at least I can make a business case to say you need the money to pay for you to have the other company, and we can sort of go ahead with that. And if it is as good, then obviously we can go for a slightly cheaper option. So she was very much, at the age of 18, was very much, oh yeah, it's not going to be as good, like this. She went away, came back about 3 weeks later, and Martin and I looked at each other because we could tell that it was better. just by the expression on her face. I don't know how you measure that, but we just looked at her and went, it's working. But anyway, I said to her, so what's it doing for you? And she said, well actually, she said, I can do more with my arm. I said, okay. So it was stopping it from shaking. So I said, what can you do? And she said, well, I work in an office and I can now pick things up with 2 hands instead of 1, which I thought was pretty good. I said, what else can you do? And she said, well, when I'm driving the car, I'm not using the knob on the steering wheel anymore. I'm using 2 hands. It gets better. Martin said I nearly fell off my stool at this point. And she then went, and she really said it like this, she went, oh yeah, she said, I can put my earrings in. And I went, pardon? She said, I can put my earrings in, but I do have to put my elbow on the table. And I went, so what? Now what's really interesting is I came back down to train the staff in 2010, and they brought her in for review. So she was then age 30. She could still put her earrings in. So I thought that was pretty good. So I was kind of hooked on it. So when I then went on to do my master's degree, which Martin was one of the people who persuaded me to do it, because I thought I'd never go to do a master's degree. But the research I did was on shaking in the upper limb of MS. And I had some quite good and promising results with that. I made some mistakes, but that's part of doing a master's degree. But generally, you know, it's been quite good. So she was really one of my biggest successes, I think. But I've actually had a lot of others where, you know, when I was in the health service, where I was actually getting some really good results.
So the idea is to wear the cycle when you exercise, is it?
No, the idea is to wear them during the day as garments. So the girl I was talking about, she puts them on in the morning when she gets up, and she takes them off when she goes to bed at night. Some people choose to put them on for what I would call the working day, so they put them on in the morning and then might take them off at tea time. Or, if you are particularly heat sensitive, and obviously wearing another layer of clothing potentially might make you warm, but it might not, because if you're shaking a lot, it might cool you down because it stops you from shaking. But if you do get quite warm, and on a day like this, you might wear them in the morning, and then you might take them off in the afternoon, perhaps even put them on again in the evening. But you kind of work it to suit you, but it just depends. Now, can you all see this picture here? This is a lady with all the pictures that we've got on this presentation. They're all people with MS. Now, she's also an occupational therapist by profession. But the picture on the far side of her hands doing this, that's her hands relaxed. Her hands are really stiff and they really tighten up, and they're quite painful as well, particularly down her little fingers. So we made her a pair of gloves. We tried the sample ones on, and we made her a pair of gloves, and you can see that immediately she's got them on, her hands start resting down on the table quite happily. Yeah? So here, her fingers are curling up quite a lot, and here, her fingers have relaxed down. Now if you then look at this one, this is where she's actually lifted her hands up off the plinth, just because I wanted to make her work a bit harder to see what happened. And she's actually still relaxed, but where I've cut the finger back here, for those of you that can see it, to allow her wedding ring not to get crushed, you can see that finger is still curling up a tiny bit there, because it's not correcting it quite enough. Yeah? But it's not as bad as it is up on that picture there. We've got some film of her in a minute doing a task, so in fact it's here. Now this is at the Bedford MS Therapy Centre, and they happen to have this thing which is 2 sheets of material with buttons on and buttonholes, and this is her without her gloves doing the buttonholes, and you can see if you watch her right hand, she's sort of having to pull up. It's quite effortful for her, but she can do it. But it's a bit of an effort and it's hard work, and I timed her as well to see how long it actually took her to do the task. So that's her doing it without the gloves on, and this is her doing it with the gloves on. And immediately you can see she's a lot faster, but also her hand position is different. She's actually got more normal position of her hands, yeah? Would you all agree with that?
Yeah.
Yeah? So much quicker. She was about 4 seconds faster doing it with the gloves on. She's now got 3 pairs of gloves. She loves it because she wears them all the time. Obviously, she's still working as an OT, so they get quite grubby. She decided she wanted to go with lilac and white stitching because she thought, if I've got to wear them, I'm going to have nice ones. That's what she does. Right, this is a lady, see it gets more interesting now, so now you can see what it actually does. This is a lady who's got weak muscles for walking at the front of her calf, and you can see her walking's not too bad. It's a little bit stilted, it's a little bit not quite fluid, yeah? So what we did was we put her in a sock, which has got lycra up the front of it, and that's her walking with the sock on. And immediately what you see is she's faster, it's smoother. You do need to still have a bit of control in that muscle. If you've lost control of the muscle, it's no good. But if you've got a little bit, it will enhance what you've got. So that's actually helping her to walk and give her a much more normal walking pattern. Yeah. I enjoy my job, you can tell, can't you? Right. This is the Bedford MS Therapy Centre again. I filmed about 3 people here. This is a lady who, she's already been wearing lycra, but she's not wearing it that morning. So you can see she's quite careful how she walks. She's a bit wobbly around her middle. She's actually got a knee brace on because her knee does snap back, but that's consistent when she has lycra as well. But you can see she is quite wobbly around her middle. She's not secure, and she's quite careful in how she walks. And we made her a pair of adapted leggings for her, and this is her walking with her lycra leggings on and her knee brace still. And again, what you see, she's faster, she's smoother, she's more in control. It's not as tentative. You know, it's the quality of her movement that's actually improved. She's still got MS, she's still wobbly around her middle, but it's just minimising the problems that she's got. Yeah?
When you say leggings, are they just
so they
are they full leg?
Yeah. So what we've got, this is a multicolour pair of shorts. I think the girls in the factory went a bit berserk with these because they just wanted to show off all the different colours of material that we have. That's a pair of shorts. If you've got a pair of leggings, then they would come right down to your ankle.
They look like normal leggings that you'd buy in a clothing store, yeah?
Yeah. But what we did with her was she had leggings, but then she had... Do you have a sock out or not?
No. It's one on the top.
One without the... That's a sock. Actually, we've got 2 colour ones actually. I'm going to upset Neil now because he's very tidy. He tidies up all my equipment and I put it all around. There's all the pink hearts on it.
Then,
Right, here we are. Pink hearts. Now the white is the lycra. So the white, I've got the sock upside down. Looks like a puppet now, doesn't it? Got it here. So that's the lycra. So that's actually going to pull your foot up. And that's what the lady who's wearing the blue sock had on. She had one of these on. So what we did with this lady was she had leggings, so they were long shorts effectively that came down to the ankle, but we made the bottoms like this. So she almost had 2 splints in one, well 3 if you think about it, right leg, left leg and the leggings. So she had those on so that it helped pull her foot up as well as stabilising around her pelvis.
Would that help with drop foot?
Yes, providing it's not complete drop foot. With the drop foot, if you've got a little bit of control, then that will help you.
But you've got a splint at the moment which keeps the dorsiflexion.
It depends whether the dorsiflexors, the muscles, if they've got a little bit, if you take the splint off and you can still move a little bit, then the sock will help. Okay. But if you take the splint off and you can't move your foot at all, then that won't help, right, because it's not strong enough. Okay? So it needs a little bit of activity. Okay? But I'll show you how it helps on the next bit of the film. This gentleman is easily as tall as Neil, if not slightly taller. Now this is him walking with his normal walking frame. You can tell he's tall because the physio on there is quite short. She's slightly shorter than I am. Now if you look at his left foot particularly, he's having problems with its catches, not all the time, but you know, but he does swing it out to the side a little bit. But if you look at the angle of his elbows, he almost looks as if his frame is too tall for him. because he's kind of doing this, right? Now, he was quite unstable around the middle and he had that foot that kept catching. We made him, he really should have had a bodysuit, but he had problems with his breathing as well. So I made him some slightly longer shorts that came up to the bottom of his ribs. And this is him walking with the shorts on, but if you keep an eye on that left foot, what you will see, in a minute, so he's standing up a little bit taller, yes, the angle of his elbows has increased a bit, but if you look, that left foot is catching possibly even more than it was on the first bit of film. Yeah? Now the reason for that is because we've stabilised his pelvis and he can't cheat and swing his leg round. So, what we then did was we put him in a left sock as well as his shorts, rather than doing what we did with the other ladies. So this is him with his shorts and his sock on. Now look at him go. Yeah? So that means it's also very important for us to make sure we assess the right things. So it would be no good just putting him in a pair of shorts, because actually you make his problems worse by just putting him in shorts, because you stabilise his pelvis, and when your foot doesn't come through, you can't then swing it around because you've actually put compression around the pelvis there. This one is just him walking back because he was so good. He didn't sit down again once I put him on, and he didn't mind being filmed from the front either. So, because he was just, you can film me anytime, yeah. So this is him coming back again. So he was very, very happy, and actually that was approximately 10 metres, and we actually timed him and the lady before, and both of them increased their times as they did the walking. Which is quite good for us, because then we can prove it to people if they need to, because that's the other thing about getting funding and things for these things. So, to summarise what Lycra does then, coming near the end, and then you can have a chance to try things on if you want to. It's going to have an effect on your muscle tone, so it should help muscle tone to relax if it's very tight. It's going to positively change that sensorimotor feedback feed-forward I was talking about, so the more accurate input your brain gets, the more accurately it can tell your muscles what to do. And then it's also going to change your biomechanics and do that. But you have to be active to get the best out of it. Do you know, I haven't had any wine this morning, honestly, it's terrible. Perhaps I put the wrong teeth in. But it also, if you're having any therapy with physios or OTs, then it complements that. It doesn't take the place of it, but it just makes life a little bit easier in terms of that kind of thing. And lots of the information is on our website, so you can actually, if you're interested in the academic side of it, you can actually pick up the references, and those are my contact details. Now, what we've got, I'm doing this slightly differently from the way I would normally do a presentation, because it's easier and because we're in a room where we can't move around quite so easily. What we have got is various bits of Lycra which we can show you. Now, one that I will put on myself for comedy value if nothing else. One of the things I have done with one or two people with MS is where their hand function has not been very good. If it's because of weakness and you put a glove on it, you potentially could make the problem worse because you add a resistance, because it's an elastic kind of garment. But there was a couple of people down in Cornwall that one of our other colleagues, Dan and I went to see, and they both had hand problems. One was a lady sitting in a wheelchair who was having trouble doing her manipulating cutlery to eat her meals and what have you. And the other one was a gentleman who used to do quite a lot of writing, and he was finding that his hand was tiring very quickly. But if we put both of them into gloves, and it made it more hard work for them. So what I then did, as I looked at them, I said, let's just think about stabilising your shoulder and see what happens if we stabilise your shoulder. I may regret this because I realise there's mirrors there, and I hate looking at myself at the best of times. I'm sorry you won't look at me, but anyway. I'll put something on Neil in a minute. He can wear the shorts. he's probably quite relieved that I'm going to put this bit on and he's not. But anyway, this is the ladies' version. Now I want you all to look at my posture, okay? So this is, you've got to work now. Look at how I stand, and I think I don't stand too badly, really. Yes? So you've all got an idea of how I stand. This is our shoulder wrap, and this is what we put on the 2 people down in Cornwall. The ladies' version is slightly different from the men's version. The men just have 1 strap that goes across the front. However, with ladies, of course, the bumps get in the way. So, what the ladies do, you're going to love this. What the company do not do is provide the tassels. Now, what's that done to my posture? Straighten me up, make me taller, I heard you say at the back there. Yeah? Now my posture is normal, hate that word again, but my posture is not terrible, and were probably all thinking, yes, she's got quite a nice posture, but it's better now, isn't it? Yes? And that's just by wearing this. Okay, come on Neil, you can earn your money now. Out here.
Does it take a while to get used to?
For some people it does, for other people it makes them feel better if they don't put anything on yet. Can you do the catwalk? Just have a little walk as normally as you can. Right, so this is the lovely Neil. And Neil is, I'm going to be nice to you. He'll know why, I'll tell you why in a minute. With physios we don't smoke.
Well, it's got square.
That's his phone probably.
Bloke things.
Well, we have a work phone or a home phone, you see.
Right.
We sound like E.T. Now, you normally wear these against your skin, not over the top of your trousers.
I won't think that.
So it is actually, no please, I might put them off. So they are easier to get on when you put them on underneath your clothes. If you have difficulty with your hand function, we can put a zip in the side to make them easier to actually get. In fact, I'll tell you about a lady in Liverpool in a minute. Right. So just think, we're going to have all these athletes we're going to be looking at over the next couple of weeks, and they all wear lycra, don't they? So it works for them too, and we do sports shorts as well. How are you doing? Now they look really, really nice.
That mirror doesn't really do anything.
No, it don't look at I found it better not to look at the mirror. Now we'll walk up and down again.
Much better.
Yes, say that again.
That's better.
Yes?
Yeah.
So my 2 little assistants, so they're very good, these 2. It's like Waldorf and Statler in the market. So that's very good.
It's more balanced.
Yes,
Nice looking at
he does.
I'd like to go for posture.
No, they're not purely for posture. They will help with muscle tone. And in fact, he's not here today, is he, Chris?
He's upstairs.
Is he upstairs? I was very mean, actually, to Chris, who works here. I put him in a pair of shorts at a conference. This is why I'm here. It's his fault. Okay? I kept saying to him, I want to put you in a pair of shorts. Now, Chris was dragging his leg, and when I put the shorts on, he walked normally. It was amazing, and he was more steady. So it will change your posture, it will change the tone in your muscles, and it will also tell you where you are in space. It does lots of different things.